Family Intervention Module for Opioid Dependence. This manual has been prepared for the conduct of the session of brief family intervention for opioid dependence. The manual is intended for use by mental health professionals or medical practitioners who would like to do brief counseling interventions for patients with opioid dependence and their family members. The manual provides an overview of the intended recipients, information about the theoretical and practical aspects of the session, and about dealing with some of the challenges. The manual incorporates principles of cognitive behavior therapy, relapse prevention, and psychoeducation. The manual is intended for conducting psychosocial intervention for adults who suffer from opioid dependence and their family members. The intervention will be provided by a healthcare professional. The manual is not all-inclusive and there may be variations in the conduct of the sessions on a case-to-case basis. The setting of the session. It is recommended that the session is conducted in the usual outpatient setting where the patients are seen for their usual clinical care. The setting may be a room or a section where counseling sessions can be done. It is desirable that the patients and the therapist are not disturbed during the course of the session. Although one-on-one sessions are preferred, the session can also be done over the phone if it is not possible to do it in person. Expected outcomes from the training manual. This training manual will help health practitioners in better understanding of the patient and their family issues coming into counseling, honing of their counseling skills, learning about the various practical aspects of conducting sessions and how to better deal with the challenges. Number and timing of sessions. A total of 3 sessions needs to be conducted where Session 1 should take approximately 45 minutes. Session 2 can be conducted 2 weeks after the first session and should take approximately 30 minutes. Finally, 4 weeks after first session, Session 3 can be carried out which should also take approximately 30 minutes. The required counseling skills, imperative for carrying out the sessions, that will be focused upon in this manual are listening, open-ended questions, empathy, communication, unconditional positive regard and genuineness. Let's go over these one by one. Listening. Good listening has a lot to do with body language and postures. It means to position yourself to the patient in such a way that lets the patient appreciate that you are aware of them, that they have your full undivided attention, and that you care about what they have to say, and, in general, them as a person. Communication skills comprises of both verbal and non-verbal communication skills. Verbal communication includes talking softly to the client, being non-threatening, non-punishing, non-judgmental, and non-hurting. Non-verbal communication includes body posture, maintaining eye contact, body cues, etc. Empathy involves developing the capability to figure out another's experience and then communicate that viewpoint back to the person to simplify what they have said. It involves nonverbal and verbal attending, paraphrasing what the individual has communicated, and reflecting on what the individual feels. Open-ended questions involve a helpful questioning method to clarify or explore thoughts and feelings of the client by asking questions that requires more than a few words or yes or no answer. Genuineness is the ability of therapists to be freely their own selves. It includes congruence between the outer words, behaviors, and inner feelings. For example, if the therapist asserts that they are happy helping a client explore a substance use issue, but their attitude, verbally and non-verbally, shows signs of uneasiness with the issue, this will become a hindrance to progress and often drive the client to confusion about and mistrust of the therapist. Unconditional positive regard involves constant kindness and expression of caring from the therapist irrespective of what is said by the client. There may be disagreements or flaws may be seen in their reasoning, but the therapist's job is not to argue them to their side but to gently encourage them to see things through the scope of reality. The therapist should also not take sides and play favorites with either the patient or their family members. Session 1. Engagement in treatment, psychoeducation, and enhancing positive support. Treatment engagement. Treatment engagement starts with welcoming those who are attending the sessions and introducing yourself. Explain the rationale of these sessions. Inform them that the first session would include information about opioid use and ways to develop positive support with the patient. What can the family member get from the intervention? This has to be explained to them at the start of the session. 1. A reduction or stopping of the use of substances by the patient. 2. Entering or staying in substance use treatment for the patient. 3. More family and social activities because of the patient's sobriety and willingness to take part in these activities. 4. Better relationship with the patient. Explain to them that the sessions will be carried out with the patient and the accompanying family member. The first session would be for approximately 45 minutes, followed by 2 30-minute sessions each 2 weeks apart. Psychoeducation. The following elements can be explained to the patient and the family member in a simple language. This information is likely to make them more aware about opioid dependence as a medical illness, and help them appreciate various aspects of this illness. However, the information can also be elicited and not just provided to the patient and family members. Some of the features of opioid dependence syndrome are as follows. Acute withdrawals. Opioids produce a characteristic withdrawal syndrome, which occurs upon decreasing or abrupt cessation or even delaying the consumption of the usual amount of opioids. These symptoms are highly variable and may include muscle aches, joint aches, increased response to pain, lacrimation, watering from the eyes, rhinouria, watery nasal discharge, tremors, sweating, gastrointestinal distress, anxiety, moodiness, dysphoria, irritability, insomnia, hot and cold flashes, gooseflesh skin, poor concentration, and increased drug craving. These acute withdrawal symptoms are usually self-limiting in nature, i.e., they usually rise up to a peak level and subsequently subside on their own even without any intervention or help. However, these acute withdrawal symptoms are very distressing and disabling for the person, and are often a cause for the person to restart or continue his/her opioid use. In most cases, once the opioid use has ceased, the withdrawal symptoms last for about 2 to 3 weeks before subsiding. Protracted withdrawals. It is the existence of substance-specific symptoms and signs which are common to acute withdrawal but which persist beyond the expected acute withdrawal time frames. These may persist for a period of up to 4 to 6 months. These include mild aches and pains, loss of interest in pleasurable activities, sleep disturbances, and cravings. These symptoms can also lead to relapse in a number of opioid users. Opioid intoxication leads to clinically significant behavioral or psychological changes. Although the classic signs of difficulty in breathing, unconsciousness, and excessive constriction of pupils of the eyes suggest the diagnosis of opioid toxicity, all of these findings are not consistently present. There may be euphoria, feeling of extreme happiness, followed by apathy, dysphoria, feeling sad or irritable, psychomotor agitation or retardation, and impaired judgment. It may be accompanied by slurred speech and impairment in attention or memory. Individuals may be inattentive to the environment, to the point of ignoring harmful events. In severe cases, drowsiness may progress to coma. Deaths can also occur in opioid overdose, which is generally found in injecting drug users. Multiple harms. An opioid-dependent user may incur harm in multiple domains of life. There may be physical complications including experiencing withdrawals, intoxication, and weight loss, psychological complications including ideas of remorse, and mood changes, family complications in terms of broken families, family fights, domestic violence, etc. Social complications may include loss of reputation or social status, rejection from social groups, ridicule from society, sometimes even inhuman treatment or physical torture. Legal complications may include involvement in illegal activities like stealing, drug peddling, petty thefts, incarceration, etc. Occupational complications including loss of job, spending less time at the job. Relapsing nature of illness. As with other substance dependence syndromes, dependence on opioids is also characterized by repeated relapses. A person may restart opioid use after periods of refraining. Such relapses are common among those who have used them for longer periods. The following may be told to patients with injecting drug use and their family members. Injecting drug users, IDU, risk and vulnerability. Injecting-related behaviors, IDUs are vulnerable to sharing needles, syringes, and other injecting paraphernalia like filters and spoons for dissolving for injection. The sharing-related behavior may be due to a number of factors, such as non-availability or non-affordability of needles/syringes, or due to prevalent practices in their group. Apart from sharing, there may be the reuse of needles and syringes and poor injecting techniques. These behaviors lead to multiple problems including blocked veins, bacterial infections, and transmission of blood-borne viruses such as hepatitis B and C, and HIV. Drug-related vulnerabilities. Almost all IDUs in India use opioids as the drug for injecting, and almost all of them are opioid dependent. In drug dependence, intake of opioids doesn't remain a question of choice for the user, it becomes a driving force. In the absence of opioids, the user suffers from such withdrawal symptoms that compel him/her to continue or restart the use of opioids. Also, if a person takes a higher dose of drugs than he is habituated to, this may result in an overdose, which is a potentially fatal medical emergency. At this time, ask the patient or the family if they have any doubts and clear them. Ask them what have they understood so far. We will now focus on mechanisms that promote positive support and possible techniques to foster them. The techniques used to foster understanding involves: provide educational information on addiction. Explain substance use starts with experimentation, positive outcomes may lead to the next stage, regular use, risk of dependence increases, high-risk use, priority given to drug use over other priorities in life, and finally addiction. Opioid dependence is a disease, not an issue of willpower. Dependent users usually don't have the ability to discontinue their substance use on their own without the appropriate treatment or tools. Addiction is a chronic brain disorder, with rates of relapse similar to relapse rates of other chronic diseases such as diabetes, hypertension, and asthma. Improve interaction skills. Interaction skills can be improved by techniques like providing constructive feedback. The family member should provide constructive feedback to the patient, which means giving feedback in a way that will lead to improvements or corrections. Engage with others. Start in small ways, talk about topics of interest, how they spent their day, talk in sentences instead of monosyllables, talk with your close ones. Practice maintaining eye contact. For the family members, maintaining eye contact with the patient during a conversation can be helpful because it shows that you are actively engaged in the conversation and interested in what the other person is saying. It also helps to improve relationships and resolve conflicts. Good listening skills, paying attention, deferring judgment, responding appropriately. Coordinate responsibilities. Encourage family members to commit to specific support responsibilities to avoid diffusion of responsibility. Responsibilities may include supervision of medications, hospital visits, occupational help, taking care of children, learning or performing particular tasks or skills, handling finances, work-related skills, etc. Strengthen bonds with positive network members. The persons in the patient's life who are not problem substance users, who are concerned about the patient and support their goal, and who are available to give support are the positive network members. Weaken bonds with unhelpful network members. Discourage interaction with unhelpful network members. These include those that support continued substance misuse. Teach methods like being assertive and refusing interactions that may minimize harm as a result of contact with them. Beware of pressure tactics, pleading, reassuring, anger, ridicule, challenging, and threatening. Need a strong body language and a confident tone of voice from the person while refusing to use a drug. Insist and stand up for one's own rights, without hurting others or violating their rights. Ask the patients and family members if they have any queries. Session 1, Summary. Facilitate treatment engagement among patient and family members by explaining rationale behind the sessions and what can they get from it. Educate them about the harmful effects associated with substance use. Guide them through the various mechanisms and methods to foster positive support. Encourage them to ask questions so queries can be addressed. Session 2, Ensuring Supervision and Compliance, Relapse Prevention. Welcome the patient and family members and introduce yourself. Start by talking about the learning of the last session, that is, information about opioid use and ways to develop positive support with the patient, and that the current session of 30 minutes would be about supervision, compliance, and relapse prevention. Ensuring compliance. Being compliant means following directions or sticking to a plan. If a person plans on taking the medications the way that the doctor explained, then the person is compliant. Being compliant is necessary to achieve the goals of treatment and ensure that medications work effectively. Not taking medications in a prescribed way could cause the person to get sick, decrease their quality of life, and increase their visits to the doctor. It can be hard to remember taking the medications if they have several different medicines or they take them several times during the day. Family involvement in medicine management will ensure greater compliance, which in turn will lead to better treatment outcomes. Ask the attending how can they ensure compliance. There are several tips and tricks that may help a person to take their medications properly. Taking the medication at the same time each day is important and makes it less likely to forget to take the dose. Setting the alarm on the watch or cell phone is a great way to remind when each dose is due. Pairing the medications with something that the person does every day. For example, if they drink tea every morning, put the medication next to the tea. This will remind them to take the medication while the tea is being prepared. Ask family members to remind them about taking medication. Ensuring supervision. Supervision may be in the form of ensuring that the person has the medication, ensuring that the person is taking it as per the doctor's instructions, checking the person's mouth if he has swallowed or not. With the supervision of dosing, access to unsupervised or take-away doses of medication is then a privilege that can be used as a motivational and reward incentive. Supervised dosing is also associated with continual contact between the client and the doctor, hence offering more contact for therapeutic engagement. It will lead to greater trust with the family that the patient is indeed taking the medication. At this time, ask the family members or the patient if they have any inquiries. Ask what could be the possible reasons that someone would continue using the drugs. Ask what could be the reasons to continue drug use after periods of abstinence. Relapse prevention. Substance dependence is a chronic relapsing condition. During the treatment course, relapse may occur, which is a failure to maintain a substance-free state over time, and the individual returns to a continuous pattern of substance use. Relapse prevention employs a set of strategies to prevent or limit relapse episodes. Role of family in relapse prevention. Family plays an important role in preventing as well as helping the patient remain drug-free. A patient's family can aid in their path to recovery by offering assistance, such as driving/accompanying them to the clinic, taking care of their children, and providing emotional support. Family functioning predicts the number of drugs used by individuals, the propensity to use drugs, and relapse tendency. A few important things to be kept in mind by family members. Drug dependence is a disease, and not a moral weakness or a lack of willpower. Avoid arguments, quarrels, justification of his or her use of the substance, or take up the responsibility of covering up for the consequences of substance use. Avoid excessive suspicion. For example, don't always start questioning whether he or she has used drugs or not, especially when he or she comes home after the day's work. A balance between supervision and excessive monitoring needs to be emphasized. Avoid making frequent phone calls to his or her friends, or colleagues to check if he or she is using a drug. Pay extra attention to their needs, nutrition, medications, health. Try to not discuss their previous drug use problems with others. This might make them feel embarrassed. Respect their privacy to the extent as much as possible. Triggers or patterns leading to substance use. Discuss with the patient and family members the following. These may help the family members to understand some of the contexts of substance use. 1. Are there specific people with whom the patient is more likely to drug, example certain friends? 2. Where do they usually drug? 3. Are there certain situations or circumstances that are more likely to result in drugging, example after arguments, coming home from work, crossing a liquor shop, times of celebration? 4. Are there certain moods that the person is usually in before drugging, example sadness, happiness, fearfulness, irritability? 5. Are there certain days of the week or times of the day that the person drugs? 6. Are there specific events, example payday, holidays, celebrations, that trigger the person to the drug? It is important for the patient and family to be aware of these situations. At the same time, the therapist should refrain from being too directive and seemingly on the side of the patient rather than the family members. Note down the triggers in a sheet of paper and ask instances about the same. Discuss what could be done to handle some of these situations, as dealing with each and every situation would become exhaustive. Summarize the session to the attending in 1 to 2 minutes. Ask the patient and family members if they have any queries. Session 2, Summary. Explain the benefits of compliance and the role of family members in ensuring patient compliance. Educate the patient and family members about the importance of supervised dosing. Explain the role family members can play in relapse prevention. Teach them about the triggers leading to substance use. Encourage them to ask questions so queries can be addressed. Session 3, Communication and Coping. Welcome the family member and the patient for the third session of the intervention. Talk about the first session in which the harms of opioids and enhancing positive support were discussed. In the second session, supervision, compliance, and preventing relapses were discussed. In the third session, discussion about communication between patient and family, and coping with substance use by families will be discussed. Communication. Families of substance users find it difficult to interact and address their concerns about substance use. When they try to comfort or care about the substance user, communication can turn into anger and resentment. Also, during the time of addiction, it can be hard to communicate with loved ones. Ask the attending to list the methods that they think are useful for better communication between them. Tell the attending that they may have come up with some ways of addressing the substance use of their loved ones. Today's discussion would be about effective ways to communicate. The following are the common strategies to improve communication between patients and families. Explaining and discussing the feelings instead of firing accusations at the patient. Respecting the patient as a unique individual. Always trying to force them into a mold could be a trigger for substance use. Avoid comparisons with other siblings or persons. Exploring feelings that result from criticism. Substance users are often criticized for their drug use, and their feelings should be discussed. Turning criticism into a positive, helpful experience. Explain criticism is an opportunity for the patient to embrace change and action. Showing warm regards and attempting to understand that recovery can be a difficult process. Never underestimate the efforts and struggles the substance user goes through. Encourage and appreciate positive changes in the patient. Building self-esteem, focusing on the strengths of the user, being a good role model for the user, and praising for the good activities. Talking about things other than substance use. Ask the family members what are the possible things that can be discussed with the patient. The topics that can be discussed may include future plans, their strategies to provide for their families, changes they want in their daily routines, etc. Be brief in the communications towards the substance users. They would not like to be lectured. Avoid talking about past incidents, grudges, and fights with the user. Be specific and avoid generalizations in the communications. Example: you always get drunk with friends, you can never be trusted. If the attending have any doubts, discuss it now. Next, discuss coping with substance use by the families. Coping. Start with explaining what is meant by coping. It can mean dealing with and attempting to overcome problems and difficulties. Ask the families how they cope with the substance use of their loved ones. It can be devastating to witness a loved one's struggle with addiction, and family members often feel helpless and stressed. Counseling sessions that focus on family interventions can provide much-needed emotional support and help family members cope with their loved one's addiction. Provide a safe space for family members to ventilate their emotions, discuss their emotional distress, and learn ways to cope with the challenges of addiction. Help them understand that their emotions are normal and that it's okay to feel overwhelmed and helpless at times. One of the following coping strategies may be used by the families. Engaged, it involves active interaction with the substance user. This can be in the form of checking up on the user and watching his or her every move. The families may feel that they are doing something productive for the welfare of the patient, but it becomes very stressful for the user. Tolerant, it involves the removal of the negative consequences for the user. This can be in the form of giving money knowing that it would be spent on drugs. The families feel that they have avoided argumentation with the patient, but they also feel that they are being taken advantage of. Withdrawn, it involves increasing distance from the user. The family tries to avoid the user as much as possible because of the drug use. They feel that by being less involved, they avoid the stress associated with it, but it leads to rejection of the patient by the family. There is no one right way of coping, and families may use more than one way at a time to deal with the situation. Explain to them that a few strategies can be used by the families to better cope with addiction. Be educated about addiction. Expect recovery by the patient, but be prepared for relapses. Set firm boundaries and clearly set limits about what will be allowed and won't be allowed. Example: no substance use inside the house, no communication when intoxicated, fixed amounts of money for daily use. Avoiding being under the influence of substances. Avoiding being emotionally withdrawn. Ask if they have any queries. Summarize the sessions to the patient and family members in 1 to 2 minutes. Session 3, Summary. Teach common strategies to improve communication between patients and families. Educate family members about the various coping strategies people use and how they can cope better with addiction. Encourage them to ask questions so queries can be addressed. Common issues encountered at the time of sessions. At the time of the sessions, the patients or their families may deviate from the topic at hand and talk regarding topics that may be related to the client or illness, but not to the focus of the session. In that case, they should be explained the focus of the current session and be advised to discuss the other topics after the session is completed. The patients or their families may say that they are already aware of some of the information provided during the sessions. They should be explained that providing the information is a means to reinforce what they may or may not know and to clear any misconceptions they might have. The sessions may be disturbed by various interruptions like phone calls, ambient noise, etc. Attempts should be made to keep these to a minimum. Outcomes expected from the session. Better communication between the patient and their family members. Reduction or cessation of opioid use. Better treatment compliance of the patient. Increased interest shown by the family members in the activities of the patient. Better problem-solving capacity of the family. Thank you for your attention. We hope the material would help to conduct sessions with patients and families better, and if needed, please get in touch with Dr. Yash or Dr. Siddharth.